Philadelphia at the University of Pennsylvania. I am doing some of my visits inpatient as well as telemedicine, just like the rest of you are. My interests are in, I take care of patients with both kidney cancer and prostate cancer, and I have been involved in many clinical trials, as well as I have been the principal investigator of some fairly large trials in kidney cancer. And Scott and Deb asked me to be involved in this conference to talk about both decision-making that you patients would make in treatment, and also things that I use to make decisions.
And thank you very much for joining us. And the other guest that we have today is Deb Maskens with IKCC. Deb, could you say a few words about yourself, please?
Certainly, I will when we launch into the presentation, but I'm a patient. I met Dr. Naomi Haas as part of my role with the NCI Renal Task Force, and I knew she would be exactly the right doctor to give this talk, so I'm really looking forward to this.
Perfect. Well, let's just jump right into it. And I'm going to control the slides here. So Dr. Haas, you just let me know when you're ready and we'll go ahead.
Okay, thank you. So I'm going to speak for about 20 minutes, and I'm going to talk about some of the things that I use to make decisions when a patient comes into the office about how to treat their kidney cancer, and things that I think are important that I know about you when I'm seeing you. And then I'm going to give you a couple of case examples to sort of walk through some of the decision making. So Scott, you can go to the next slide. So I look at three different types of tools. One is the patient, the cancer, and the treatment options. And you can go to the next slide. So when you walk in the door to see me, there's a lot I don't know about you. So one of actually a patient told me or taught me to do this. What they said is, I would like to tell you something about myself that you might not already know. And so often I will say to a patient when they come in, tell me something about yourself that I wouldn't ordinarily know. And that does two things. It tells me a little bit about yourself, but it also actually helps me remember you, and it really sticks in my mind, you know, and makes you an individual. So in addition to most of the time you would be coming in to see me because you have kidney cancer, and you may have an early stage of kidney cancer because that's one of my areas of expertise, but you also might have kidney cancer that has spread to other parts of your body, and that's another area that I have expertise in. And so I'm looking at that, but I'm also looking at some things about the rest of your health, and I want to go through some of these. So go to the next slide, please. So the first of these is called a performance status. And there are two scales that have been developed over the years, and they're both shown on this slide. And these reflect your level of activity. And one of them is called the ECOG WHO score system, which is listed on the left. And the other is the Karnowski score system, and that's listed on the right. And they basically look at the same thing, and they look at your level of activity. If you're pretty much asymptomatic and you're able to carry out all the things that you did before you were affected with kidney cancer, and you don't have any restrictions, and you know, you're basically in good health, then you either have an ECOG score of 0 or a Karnowski score of 90. If you have a couple of things that might limit you, for example, you might need to take a nap in the middle of the day, or you have a little bit of pain, but you're basically able to do most things, then it's a 1 or a 70 to 80. If you're able to do most of what you need to do, but and you're up for more than 50% of, active for more than 50% of your waking hours, then you have what's called a 2 or a Karnowski score of 50 to 60. If you're really, much more limited and you're spending a lot of time in bed or the chair, or you're bedridden, then the numbers are shown lower on the bottom of the screen. And the reason that this is important is we know from doing a lot of clinical trials that patients are much more likely to tolerate treatment of any kind, whether it's in a clinical trial or whether it's any kind of commercial therapy, if you have an ECOG performance status of 0, 1, or 2, or a Karnowski score of 50 or greater. And so these are things that we don't necessarily, we would ask you what you're doing in a typical day. And we would also know this by sort of seeing how you arrive for your visit and, a bunch of things like that. Next slide, please. The other thing that I like to do, and I'm not always good at doing this because as you know, the clinic schedules for any doctor that you go to see tend to be pretty busy, and there's a lot to talk about in a half an hour period of time. But I think that having conversations about goals of care is a very important part of any kind of medicine, whether it's internal medicine, cancer therapy, surgery, anything. And these conversations often occur when people aren't doing well and they're really sick. But they're actually a pretty good thing to do when you're well and when you walk in the door and when you're first meeting your doctor. And what they do is they tell me what's important to you in your care, and it also I think makes the communication a little bit better. If I know what your goals are and maybe you haven't even thought about this or need to articulate it, it's a good way to do that, and it's also a good way to communicate with your family. Next slide, please. So what I did in these is these are, we don't always talk about every single paragraph in these conversation examples, but what I will often do is take 1 or 2 topics from these conversations and start with them, and then I might have another conversation later on in your care and dig a little bit deeper. Or we might do the whole thing, at the very beginning, depending on what the situation is. But there are things like just, I'd like to talk about what's ahead with your illness and do some thinking in advance and make sure that we can provide with the care. And so I'll ask you what your understanding is of your kidney cancer. Do you know where it, is it localized? Do you know, where it is? And, what have you been told so far? Because 2 things. One is I make sure that you have a good understanding of what's going on. And I also make sure that, that we're on the same page and that you're on the same page with other doctors that you've seen. And then I'll give you my understanding. And sometimes if I'm worried about something, or if I'm trying to, convey that the treatment might have a lot of side effects, or we're not sure what the outcome is going to be, we might use some of the other paragraphs listed below here. Next slide, please. And then I think these are really good things to talk about at any time with your family and with your doctors. And that's, what are the most important goals? Like if you get sicker, do you want to do everything? Do you, I have patients that they don't care if they're crawling in the door. They want to do everything. They just have a comfort zone with doing that. And I have other people that are just terrified that, that they might have a lot of side effects, or they're very clear that, that that there's a certain amount they want to do, and then they draw the line. And these are all things that if you don't talk about them up front, it's kind of difficult to, to all be on the same page and stuff. So even if your doctor doesn't bring up these things, these are good things for you to think about and to bring up with your doctor. Next slide, please. So then the other things that I look at are financial things. For example, I had a patient this is a patient with prostate cancer, but he came in and he was getting radiation therapy, and this is about 10, 15 years ago, and he kept losing weight. And after a while, I found out that he didn't have a job, he didn't have good medical insurance, and he basically wasn't eating because he had a $30 copay with every time that he came in the door and was parking and stuff. And so instead of buying groceries, he was paying that copay. Well, that's something that, that live and learn, I've learned to look at these things. But these are very important things as far as whether people show up for their treatment and how much we're asking them to do. So if I have a really, what I think is a really great clinical trial, but you have to come in every 3 days, but your work, you might lose your job if you do that. I might still tell you about that clinical trial, but that might not be the best thing for you to do. And the more we know about it, also the more we can help. So if you have a huge copay with a pill therapy, for example, for your kidney cancer, sometimes what we do at Penn, at least, is we alert the pharmacy, and the pharmacy will often have grants that they work with either the industry supplying the drug or with the insurance company to come up with ways to provide assistance for drugs. And, and sometimes what might have been a $1,500 copay might be $5, but if we don't ask about it, we don't know. And even things like taking care of your children and transportation issues, if you're riding the bus and the bus is late, or if you need a car to, bring you in, these are other things that we need to know about. Next slide. So the second is the cancer. And obviously, there are many different types of kidney cancer. The World Health Organization right now lists about 27 different types. We are still a little bit in the dark ages with this, in that all of our definitions of kidney cancer right now are still driven by what it looks like under the microscope. And there are many really relevant molecular tests that I think will be coming down the pike that will probably help to predict a little bit better who is likely to respond to a particular type of therapy or not. But right now, in the real world, we're still very much relying on what it looks like under the slide. And most of our testing is done in clear cell kidney cancer because that's the most common type of cancer. And so it's easy to do trials where there are many, many patients who can participate. But we know enough now about types of cancer that aren't clear cell that we can usually steer the ship in some better directions and stuff for other types of cancer like papillary and even chromophobe and collecting duct and medullary kidney cancer. I think the Judy Nicholson Kidney Cancer Foundation has even done a program, I think, on medullary cancer recently. Next slide. Another thing that's important is your stage. So obviously, if you have an early stage tumor and we can direct you towards surgery, or if it's a really small tumor, it might even be able to be treated with freezing it, or with in some cases radiation therapy. A lot of those patients, all we need to do is do that and then do close surveillance. But if your kidney cancer is more high risk and it involves lymph nodes, then often there are either adjuvant or neoadjuvant, therapies before surgery or therapies after surgery that you might be interested in hearing about. Those are generally clinical trials. And if it's metastatic, if it's spread to other areas of the body, then there are both clinical trials and many, many different commercial therapies that we can offer. So that's the other thing that we look at. And then next slide, please. And then this is a very interesting scoring system that you may or may not be familiar, but more and more of us are using this also. And what I'm showing on this slide is something called the International Kidney Cancer, it's a scoring system called the IDMC, and it was actually developed by a Canadian, Danny Hang. But it looked at many, many patients who had been on clinical trials for kidney cancer and identified the 6 things that are listed in the box to the right as important things determining how your kidney cancer is going to behave. So one of them is if you walk in the door and you already have metastatic disease, then your diagnosis would have been less than a year from the time you developed metastatic disease, because you had it at the same time. But if you had your kidney cancer removed and it came back 5 years later, then that wouldn't apply to you. If your level of activity, again, here's that Karnowski performance status. If you're not feeling well and you're spending, about 50% of your time in bed, then that's also a risk factor. If you're anemic, in other words, if your hemoglobin level is lower than the lower limit of normal. Now, this is a pretty common thing, and I don't think it's a huge deal. I mean, you might have a hemoglobin of 12 and the upper limit is 12.9, but we still count it. It's probably a little bit more relevant if you walk in the door and your hemoglobin is in the 6. Your corrected calcium was another blood test. And if your calcium is really high, it can make you nauseated and sleepy and constipated. The other 2 interesting things that you wouldn't ordinarily think of that he came up with from looking at all these patients were an elevated neutrophil count, which is part of your white blood cell count, and the other is an elevated platelet count. And to the left here is a survival curve, and I'm not really excited about showing survival curves, and I don't want you so much to look at the overall survival and which is on the y-axis, and the x-axis is the time since therapy. But I want you to look at, if you've got none of those things, you're favorable. And so you have the blue line at the top, and you're likely to do really, really well for a long time with your kidney cancer. But if you have a lot of these things, if you don't feel well, if your labs are really out of whack, and if you walked in the door and you have, kidney cancer that's spread, those are people that we consider, and I know Deb doesn't like this term, and I'm only calling it poor because that's what it is in the paper, but we all decided that it should just be unfavorable risk rather than poor risk. And the point of all these is that we're looking to make all of these curves look better. And so if we understand our population of patients and who we're treating, it helps us figure out, while we're treating with different clinical trials, what we're likely to see and whether we're doing better if we offer a particular type of treatment. Next slide, please. I also wanted to just spend a little bit of time going through definitions of clinical trials, because I think when you hear some of these things, it's a language it's a little Greek and isn't familiar. So the first slide here is phase 1, phase 2, or phase 3 trials. And these are all relevant in the treatment of any type of cancer. But what phase 1 trials are doing are asking, what's the right dose? And so these are trials that are generally smaller trials, and they're generally using different doses of a new drug coming out. But it might also be a drug that's been around a little while, but they're looking at different doses in a different kind of cancer. A phase 2 trial is asking, whether we already know what dose, and we're looking at the dose, but we're asking specifically, okay, this works in prostate cancer. Does it work in kidney cancer? Or it might be, for example, savolitinib is a drug that's used in papillary renal cancer. And there was a trial recently published that looked at whether patients had mutations in MET, which is a gene, and whether the drug worked better. So that would be an example also of looking at a moderate size of patients with a particular drug. And then phase 3 are these big trials that enroll, hundreds of patients or thousands of patients even. And they're asking that these are the trials that are bringing a drug to commercial approval. And they're asking, is this treatment better than the current standard of care? So next slide, please. So here is an example of, sometimes things are a phase 1 and a phase 2. This is a trial developing the drug Opdivo or nivolumab. And you can see that this was published 5 years ago already. So that trial was being conducted probably 8 years ago. And it was when the drug first came out, and they were looking at 2 different doses. They looked at 30 patients. Some of them got 1 milligram per kilogram. Some of them got 10 milligrams per kilogram. And nowadays, we actually treat patients mainly with 3 milligrams per kilogram or a set dose. But what they were looking at here was 2 different doses. So it was phase 1, but it had already been looked at in melanoma and in lung cancer. And so it was also, we called it a phase 1, phase 2 trial. Next slide, please. This is an example of a phase 3 trial. So this was a trial that led to the approval of nivolumab and ipilimumab, which are commercially known as Opdivo and Yervoy. And it has some other words in it that I'm going to explain in another slide. But basically, patients who had clear cell that was metastatic signed consent to be on a trial, and then a computer who didn't know who they were, and the doctor didn't get to choose. It was a computer program, a statistical program. In this case, patients were randomly assigned 1-to-1. So the computer didn't know who you were or anything about you, but just a kind of a number that was anonymized. And it got your registration information and spat out you were assigned to arm A or arm B. So that's what randomization is. And this trial, sunitinib, had already been approved as a standard of care in metastatic kidney cancer. And so this trial was looking at both overall survival and progression-free survival, which means does the drug shrink the tumor? Does it make people live longer? And does it keep the cancer from spreading? And it was looking at all these endpoints versus Sutent. So that's an example of a phase 3 trial. And many of you would know that this led to the FDA approval of Ipi/Nivo in treatment. Next slide, please. So randomized, we just talked about that. Placebo-controlled is another thing that is very confusing. And I hear this more often than anything else as a question. When I talk to people about a clinical trial, patients will say, am I going to get a placebo? And it's really important to know that a placebo isn't always used in a trial design. The most common situation would be if no treatment is what is an appropriate treatment. In other words, if you're having surgery and then you had the opportunity to get a drug, but it would be, most of the time we would just follow you and wouldn't treat you. That's a situation where a placebo could be used. It could also be used in a setting where you're getting treated with a drug and they're adding another drug in. And so you're getting a drug no matter what in both arms of the study, but they're adding another drug and they're trying to figure out if adding that other drug does things to make the treatment better. Crossover is another confusing term, but what happens is, for example, one of the trials open right now is the Hif Inhibitor, which is a trial that Merck is developing, and it's a different target against blood cells. And it's for patients who've previously received either a drug like Opdivo or Keytruda, and they've also received a Vegf inhibitor like Sutent or Axitinib, Inlyta. And they're randomized on that arm. One arm gets the Hif inhibitor and the other arm gets a drug called everolimus or Afinitor. And in that particular trial, the company will not give you the other drug. So you can't, if you're assigned to one arm, you can't go over to the other side. You can't have crossover. But sometimes you do have trials where you can go on one drug and they look at how long you're on the drug, and then you can cross over to the other side. And some examples of that are some earlier trials that were done, for example, with Votrient versus Sutent, the Pisces trial, for example, where patients were on each of these drugs, and then the doctor didn't know and the patient didn't know what they were on. And then after about 12 weeks, they crossed over and they were treated with the other drugs. So that is something that is done. A registration trial is typically done in a phase 3 trial. And that's, again, the data is used by the Food and Drug Administration and can be used for approval of the drug. Next slide, please. So again, this is an example of a placebo-controlled trial. This was an adjuvant trial that's still accruing for patients with high-risk kidney cancer, and this is one where patients, after they have their surgery, can go see a medical oncologist and be enrolled and get either Ipi/Nivo or they get a placebo infused. And this one is still accruing, and I think, you know, a lot of times people feel that if you use a placebo that it might make the doctors and the patients kind of, everybody treat everybody sort of the same and act the same, and that's one of the reasons people consider placebos. Next slide, please. But here's another trial. This is the Prosper trial, and this is also in this space. And this is how you can do it without a placebo. But this one is a trial that requires going to a medical oncologist or having a conversation with a urologist before you actually get your surgery. And in this one, if you present with kidney cancer that's fairly limited, it's either limited to your kidney or you have maybe 1 or 2 spots that could be treated in addition to that, you could go on this trial and you would be randomized. You would be assigned to get either a treatment arm where you get 1 dose of Opdivo, followed by surgery to remove your kidney cancer, and then you get 9 doses of Opdivo. And you'd have to have a biopsy because you were getting a drug before you got the surgery, so we need to know that you actually had cancer to give you the drug. Or you would be assigned to routine care, which is getting your surgery and still getting really good follow-up and getting observation. And in this trial, patients know actually which arm they're on, and there's not a placebo, and you know the patients actually were we had a lot of patient advocates, including Deb, that were involved in the design of this trial. Next slide, please. So I better speed up a little bit, but treatment options, commercial, you know, some of the other questions, pill or intravenous. In other words, if you have a huge copay, if you're going to have to pay $5,000 for a drug each month, then, you know, sometimes your insurance, usually it's a little easier to cover people with an intravenous therapy. So that might sway me to talk more about intravenous therapies for you than a pill therapy. Other things, though, I'm going to use as patient examples in the next few slides are kind of medical reasons that might steer us towards one treatment versus another. Next slide. Before we do that, this is the one other thing that you should know about that a lot of doctors use. I think the Canadians have sort of a similar thing, but this is the NCCN guidelines, and this is sort of a roadmap for any doctor taking care of kidney cancer or any kind of cancer for that matter. It covers all kinds of cancer. I'm just showing you the one for kidney cancer, but this is based on kind of a consensus of about 40 doctors who are all experts in the field getting together and looking at all the data and then recommending particular treatments based on the outcomes. And these are all commercially approved drugs, but you can see that these are lists of things that are preferred regimens. And you can see over on the left there, it says risk, favorable, poor, intermediate. That's back to that IDMC criteria. And it shows you that there are certain drugs that perform well in these settings for particular patients. So that's the other thing that we use to make decisions. Next slide, please. So I'm just going to go through to finish with a couple of cases. So this is a 67-year-old man who has congestive heart failure. He had a heart attack a number of years ago. He's on 3 medicines for high blood pressure. And he walks into the office and he has a newly diagnosed clear cell that's metastatic to the lungs. He has about 10 nodules in the lungs. They're not small. They're not something that we can, sometimes if they're super small, we can just watch these sort of things. He has a large kidney mass. He walks about a half mile every day, but he needs to rest. He gets a little short of breath, but this has been something that's been this way for the last 5 years since he had his heart attack. Now, I know when we talked about performance status, we said it was how it was before you got cancer, but if you're disabled and you have a lot of other variables, we still take that into account if we think you're going to have a tougher time with certain types of therapy. So it's good for us to know all of these details. He is anemic, he has a low hemoglobin, but his calcium, platelet count, and neutrophil count are normal. Next slide. So when I'm looking at him, I'm saying his Karnowski performance status is probably 70 because he has to rest and he's not feeling that great. And then I'm looking at the other risk factors. So that Karnowski performance status we call KPS. He walked in the door, he had metastatic disease, so he has time from diagnosis to mets of less than a year, and he's anemic. So he has 3 points. So that puts him in that more kind of unfavorable risk or poor risk. And I'm also looking at a couple of other things here. One is his high blood pressure, and the other is his copay. So the questions are, should we use a pill therapy or an intravenous therapy? And should we use an immune therapy, which is an intravenous therapy, or should we use a Vegf receptor tyrosine kinase inhibitor, which is a pill? Next slide. So some things that are important to remember about Vegf inhibitors, these are things like Sutent, cabozantinib, Lenvima, axitinib, they can cause some tiredness, but they can cause high blood pressure. And in some patients, in about 4% of patients, you can actually get some weakening of the heart muscle, which can improve if you get a break from the drug. But if you have congestive heart failure, these are things that are pretty important to keep in mind. Next slide. The other thing is we like you to actually have a little bit of hypertension. But in this case, he's already on 3 medications. We know that if the drug is hitting the target, if you get a little bump in your blood pressure, and I'm talking little like 10 millimeters of mercury or so, I like to see that. But this is somebody I also have to make sure that we're not tipping him over the, making him sicker by, and what other medicines are we going to add and stuff. So we know that if you get a little bump in your blood pressure with these pill forms of therapy, that it's a good thing, and it demonstrates activity of the drug and generally responsiveness of your cancer. Next slide. So when I'm looking at this guy, there's probably 3 different things we could do. If I have a clinical trial for him where the medication isn't going to cause high blood pressure or congestive heart failure and is going to cover a lot of his costs, I think that's a good option. If I'm going to treat him commercially, I'm really leaning towards using the immune therapy, because the immune therapy isn't going to affect his blood pressure. Also, it's intravenous, so it's much more likely to be covered by his insurance without giving him a huge copay. However, there are 2 kind of main options listed for choices in patients in this setting. One of them is ipilimumab and nivolumab, and sometimes I use just nivolumab alone. And the other one is Keytruda with Inlyta. And Inlyta is a pill form, but I might still consider Inlyta in this setting. I might do Ipi-Nivo, I might do Keytruda and Inlyta. The reason I might do Inlyta is that it has a very short half-life. So if he has side effects, I can really go down low on the dose, give him the baby dose that might not affect his blood pressure. And the other thing is it doesn't hang around long in the system. So if he has problems, I can hold the drug and he'll probably be better in a day or two. So that's sort of how I make that decision with this guy. Now the next case, I think, is the next slide. Yeah, it's a 56-year-old woman with a history of rheumatoid arthritis. So that's an autoimmune thing. Rheumatoid arthritis isn't osteoarthritis. It means your immune system is affecting your joints. And she has a clear cell kidney cancer that spread to the bone. Her kidney tumor was removed 4 years ago. So she's not newly diagnosed. That's an error in my slide. But she has pretty good health insurance. And even though she has rheumatoid arthritis, she walks every day and she's on Plaquenil or hydroxychloroquine, which is controlling her symptoms. And her labs and stuff are pretty normal. So let's go to treatment choices for her. So next slide. So she's got a Karnowski performance status of, somewhere between 80 and 100. She's active. She might have a little bit of achiness in her joints. And she really doesn't have any of the IDMC risk criteria, so she's a favorable risk patient. So really, in that category, I didn't spend a lot of time on that NCCN thing, but you could really use a lot of different regimens for her and not go wrong. Next slide. But these are some of the things that we know immune checkpoint inhibitors can cause. They can make her rheumatoid arthritis much, much worse. They can cause a lot of autoimmune symptoms. So this is somebody that if you put her on an immune checkpoint inhibitor, you may end up needing to put her on steroids, and you might make her rheumatoid arthritis much worse. So you may want to go with a different drug first. Next slide. So again, these are choices we could consider, but this is a patient that I might actually consider putting on either cabozantinib because that has bone activity, or I might put her on a drug like Votrient. If she really, really wants to be on an immune drug and is willing to, think about a potential risk, I might offer her Keytruda and axitinib. I probably wouldn't give her Ipi-Nivo because I'm sure to really make the rheumatoid arthritis much more of a problem that way. Next slide. And I think that's all. And I'm happy to take questions, or we can go right to Deb and then maybe take questions at the end.
Great.
It's probably best if we go with Deb's, and then we can take questions at the end, because I know we're running out of little time. And if we need to divert the questions to a Facebook forum or something afterwards, then we can.
Yeah, sorry I took so long.
Okay.
No,
Great.
it was all wonderful information, and
good.
thank you so much.
It was good. Okay, so can you hear me, Scott and everybody?
Yes, ma'am.
Yes.
Okay, it's great to be here. So thank you, Naomi, for that excellent presentation. I was writing some notes off to the side, so we're always learning. So what I'm hoping to do today is to throw a little bit of patient perspective and perhaps give some practical tips to patients about how to achieve this goal of shared decision making. Getting a little bit of feedback on a little bit of an echo or some noise, but anyway, I think we're okay. We'll go. Next slide, please, Scott. So this is a little bit about me, and I'm not going to go into this in great detail because it's only really of interest to me. But just to let you know, these are my credentials. I'm not a medical oncologist. I have had no medical training, so be really careful when you listen to me. But I've had kidney cancer since I was 14 when I had my full nephrectomy. My kidney cancer did come back, which is a lesson for everybody to maintain your surveillance scans and beyond 5 years. Mine came back 22 years later and was like a paintball explosion inside my abdomen. And so since then, I've had many, many surgeries. I jumped at a chance for a clinical trial in 2006 when Nexavar was one of the first PKIs that came around. That was really miserable on that drug, hated it. Some surgery, I did a trial. I'm a Canadian, as you may be able to tell by my voice. I live near Toronto, but I was able to join a trial at the NIH just outside of Washington and was on that trial for 3 years with a drug that has actually not come to market, but it was good for me. And then I've done some SBRT, which is a form of radiation, and some surgery. Last year, I joined another clinical trial so that I could get some genomic sequencing done on my tumor, and I'm continuing to learn. But the approach in my particular kidney cancer is really one of doing it as little as we have to do at this point, because I'm really prizing my quality of life off of systemic therapy. So that just gives you a sense of my background. The pictures are of me sitting on the steps of the Abe Lincoln Memorial in Washington. This is my one-person protest against kidney cancer, and I do hope to be back when the borders open again, and I will sit on those steps and take a picture with this crazy hair. Okay, next slide, please, Scott. Okay, so what I'm hoping to cover, what does this mean to patients? And I did reach out on smartpatients.com to get, I've got some quotes from some other great patients. What are the barriers that we always talk about, and what tips can we share? Next slide. Okay, so as Dr. Haas has said, there has been a shift. In years gone by, it used to be physician-directed care where the physician would tell you what you're going to do. But now that we know that shared decision-making is this new buzzword, in a sense that it's the cornerstone of truly patient-centered care. And that means that it's your values and your preferences and your goals that matter here. So the doctor is going to have some ideas, but it's really up to you and to fit this in your life with your values, because nobody else is like you. And as Dr. Haas has said, the evidence says that shared decision-making, when it's done well, reduces decision regret, it improves patient satisfaction, it improves adherence, which is a word, sometimes doctors use the word compliance, which we kind of shy away from. Adherence means that, yes, you're going to go to all of your appointments, you're going to get your scans, you're going to take the pill every day, etc. There's also evidence that shared decision-making decreases healthcare costs, which is particularly important in countries like Canada. It decreases those unwanted crisis care visits to the ER. And there's emerging evidence, and I want to do a hats off to the IKCC here, that's the international group, that increased patient activation, which means being more involved in your healthcare, improves patient outcomes, meaning hard patient outcomes such as survival, overall survival. So there's evidence that you being involved in your own healthcare will actually help and improve your survival. Next slide, please, Scott. So what does it mean to patients? I need to emphasize here, this is not a one-time thing where you went in and you did this thing once, but it's a collaborative, ongoing process that involves you, your physician team, your caregiver, and it means there's respect for what you decide to do, that you're not going to let down your doctor by not choosing the clinical trial. But it really is about you. And if you choose to take no therapy whatsoever and say, you know, I'm going to just leave things be right now, I've got a lot going on in my life and I'll come back after the next set of scans, that's okay. It's your call. The doctor may have different goals than you have, but it's ultimately up to you. And it's something that you revisit over time. I know as a patient, when I was 36 and widely metastatic, I was prepared to be very aggressive with my treatment. I don't want to be that aggressive anymore. I know what it's like to be in big surgeries. I don't want to do that again. And I'm not prepared to accept, living in the toilet every day either. So your goals do change over time. But at the core of it all, it means that you have a right in whatever country you live in to be informed of all the possible treatment options and their risks and benefits. And sometimes that means being informed about treatment options that aren't with the current hospital where you're being seen. They might be at one hospital over, one state or one province over, but you should really be told about all the options, even if they're not with your local doctor. Next slide. So what does it mean? Some great quotes from these. These are the expert patients who are on smartpatients.com. Someone who said, I feel the final decision should be mine most of the time, unless it's life-threatening. Just give me the options. And absolutely, I agree. If you've cut your leg off accidentally, you don't want to engage in shared decision-making. Somebody should do something about that. And there are times in life when you do have to say, okay, I need to just pay attention here. Someone else said, make sure you choose a doctor and team, keyword on team, who respects that you've done your homework, a real partnership where you feel heard and respected. I think those are powerful words. Somebody said recently on Smart Patients that a doctor laughed at them when they went to ask about surgery. They thought it was a ridiculous question. There are no ridiculous questions. So if a doctor's laughing, that says more about them than it says about you. Go ahead, next slide. So the barriers, the hurdles. So we've asked now, is shared decision-making really happening in kidney cancer? And so the last data that we have, which was almost 2 years old now, we did a survey of 2,000 patients where almost a third of the patients said, my doctor decided for me. So the good news is that 2/3 of patients are engaged to some level, but 1/3 of them were still saying, my doctor decided for me. And that was across all stages of disease, including stage 4, where I really find it hard to accept that a patient would want to abdicate all of their decision making. And because that is a global survey that involves countries, far-flung, I just popped in the USA and Canadian numbers in there, that we're not immune to this, that there are still patients who are saying, my doctor decided for me. Click to the next slide. And I should say, Scott, as you just go to the next slide, but if that's what they want, if the patient wants the doctor to make all the decisions, then all the best to them. So the barriers, I've used a slide, a picture here of a great book. This is a Canadian colorectal cancer patient who wrote a book, The Cancer Olympics, and that's often what it feels like we're doing, that this is like a race jumping over the hurdles, that there's always a hurdle. Sometimes you get to a flat space where you can run for a little while, but then somebody throws you another hurdle to jump over. So with shared decision-making, these are the barriers that patients said that they encounter. One of them is the physician's time and demeanor. If you don't like their demeanor, you can go somewhere else, right? But time is a real issue. We don't have an hour and a half with our physicians when we meet. So learning how to use that time is a key thing. The perceived urgency of, this is cancer, and I should make a decision really quickly because my life is on the line, when most of the time, a kidney cancer decision isn't a medical emergency, that you can take some time. And in fact, asking your doctor, how much time do I have to make this decision? That might be a really helpful thing because you don't need to be rushed into it. The third one is knowledge, language, literacy, culture. I'm sure for many people in Dr. Haas's slides, there's language there that is just not language that we use every day. PFS, OS, QOL, all of this. So it's okay to say, I don't know that language, and please explain that to me in lay language. It doesn't mean that you're a stupid person. It means we just speak different languages. The number 4, the fear of offending the doctor. I'm a Canadian who tends to be polite most of the time, but I would say go right ahead and offend that doctor, because it's your life. And particularly when it comes to asking for a second opinion, I often tell patients that if it was the doctor who had this diagnosis, they would be getting a second opinion. So don't worry about offending them. Always be respectful, etc. But don't miss getting a second or third opinion because you're afraid of offending somebody. My goodness. Number 5 says that there are no right answers, that if we had a cure that worked 100% of the time, it would be a lot easier. We're not there yet. So we have a lot of uncertainties. I say there's no black and white, there's shades of gray. We're not going to talk about 50 shades of gray, that's something else. But you're going to make a decision that is somewhere in the middle. The personal situation, and Naomi covered that. And number 7 I will speak to is sometimes think about the family and loved ones. Sometimes it seems that it's the family and loved ones pushing a patient to make a decision, that they don't want to see their loved one give up the, air quotes, the fight against kidney cancer. But as a patient individually, you need to have that conversation with your family and loved ones, and don't do a treatment for somebody else, because it's you who's going to be the person in the middle of it all. Next slide, Scott. So the tips that we can share, everybody on Smart Patients will tell you, get a second or third opinion, someone with expertise in RCC. I'm going to throw a caveat on that. If your first opinion is with somebody like Dr. Naomi Haas, you may not need to get a second opinion. What you need to be asking is, how many kidney cancer patients do you treat? And with your specific type of kidney cancer, for example, if you have a non-clear cell, so you're a chromophobe, how many patients with chromophobe disease do you treat? That's really important. And ideally, you're going to a center where they offer you clinical trials. There is some data that says that patients who are treated at centers where they offer clinical trials do better. And that is regardless of whether they're actually on the clinical trial or not, just that they're being treated in the building. Think about that. So we build yourself an expert team. It's not a solo sport. So I have, for example, a uro-oncologist. I have a medical oncologist. I have a couple of radiation oncologists, a nurse. I go to somebody for some psychosocial support when this all gets too much. And you're not alone on that. 96% of the patients that we survey globally said that they are impacted psychologically by this disease. So it's huge. Great family doctor, a caregiver and advocate patient organizations like the Judy Nicholson Foundation in the US. There are others. There's the KCA, there's Kidney Can. In Canada, there's a great organization called Kidney Cancer Canada. And there's you in the middle of it all. So you don't discount the role that you have in all of this. Next slide, please, Scott. And the tips, these are from Smart Patients. Learning as much as you can about your individual diagnosis, because sometimes we have like apples and oranges talking to one another. So it's very different depending upon your histology, your subtype, your stage, your grade, your options. Sometimes it can be frightening if you're reading about somebody who is not doing very well at all, but to realize they have a completely different biological disease than you have, and you're in a very different stage than they were diagnosed with. So it's hard sometimes when we put them all together and we think about vanilla kidney cancer. It just doesn't exist. So get copies of everything. I carry around huge files with me when I go and visit my oncologist because I want my scan reports and everything organized. Writing down your questions and narrowing them down. You're not going to be able to ask 37 questions in your first appointment, but narrowing down to what the important ones are. Learning to talk to your doctor. Someone said, be brief, let them finish, because sometimes we're so keen to get in there with our ideas, but your doctor's done some thinking before you're actually in the appointment. So let them finish and then, respectfully ask your questions. Some patients send their questions in advance, either through a patient portal or via the nurse. Sometimes I email my medical oncologist to say, I'm going to see you on Thursday, but just so you know, I wasn't feeling so great when I had that last scan. I think I had something brewing, so don't worry if the lymph nodes look a little bit better. I don't know if I'm sending that to him for his benefit or for mine, but sometimes we have a little bit of conversation just so I can give him a heads up that one of us isn't going to freak out when we see the results. Next slide. So other tips from other patients, making sure you articulate. So whether maybe you see yourself in one of these quotes of, I'm willing to take on high risks to achieve a possible cure. But to say that, and then maybe you can have that conversation with your doctor about how achievable cure might be in your situation. Someone like me, I say I want to maximize my quality of life with minimal side effects right now, and mostly the team goes along with that. If you don't have access to a bathroom, if you want to play golf 3 times a week, I've never learned, your goal is to walk your daughter down the aisle, and that is scheduled for 3 months from now. Maybe you can postpone treatment, you know, be well at your daughter's wedding rather than to be in the toilet and not be going down the aisle. So next slide, please, Scott. Oh, we skipped one, back one, please. Just, this is a quick memory aid. So bran, when you've had surgery, everybody talks to you about the importance of bran if you're on painkillers. But think about bran this way. What are what are the benefits of what you're proposing? What are the risks? There are very real risks, and particularly with immunotherapies, there are very real risks that you should be aware of. What are the alternatives to what you're suggesting, doctor? The N is, what if I do nothing? And nothing doesn't mean giving up. It might just mean nothing for now, for 3 months, for 6 months. What if we wait and see how the disease moves? And who gets the final say in all of this? You do, as the patient. And just an acceptance that, you know, I'm not in a good place to make this decision right now. So no decision is a decision you can make for now. And then you can call it in once you've had some time to think, or you can make another appointment to see your physician. But don't feel compelled to make a decision on the spot. Next slide, please. So this, the closing is that every choice you make is a trade-off, that there's that quality, quantity, it's like a slider. Where do you fit on that? You're going to be in different places at different times. So to make a decision that's right for you, you need information. And that information, my view, needs to be evidence-based versus anecdotal. And so not everybody's going to agree with this, but I'm going to say be really, really careful about the Facebook groups out there, because there's a lot of times when we're reading about things that really are ahead of the evidence. And it's great if you want to be a pioneer, but sometimes they really worry me. So keeping your information evidence-based, making sure that it's balanced, that it's objective, and it's not been biased, because as Dr. Haas said, these are commercial therapies with a commercial intent to treat as many patients as they possibly can and to make money while the sun shines. But just be careful, but not all information, especially on those manufacturer websites, TV commercials, etc. Not all of that is perfectly forthcoming. And it has to be applicable to your case. If you've already had 5 treatments, then jumping at a double immunotherapy combination has a different risk benefit. So, so those are my thoughts. The last slide, Scott, is just about the shared decision-making guides. Holding one up here that you can barely see, but with the International Kidney Cancer Coalition, I think Brian Lewis is on this call. He's on the board. I used to be on the board and helped develop some of these. These are called patient decision aids. There is a great one on small renal mass. There's another one on metastatic kidney cancer, and one just on some basic terminology. These are great little workbooks for you to work through to try to figure out where you sit personally. It's kind of like, you know, risk profiling yourself and what you might be willing to accept. So I would urge you, there's the link there. They're great little guides. They're very friendly. They were written by patients with an expert international medical advisory board. So you can trust this information. There's not a commercial bias in that. I've given you my email address. I'm happy to hear from patients. I most prefer when patients post on a platform like Smart Patients, because everybody then gets the benefit of the exchange. And as I said at the beginning, I might not be right. That's my Twitter ID at Deb Maskens, and on Smart Patients, I am Deb M, or Canada Deb sometimes. So anyway, with that, I'll turn it over to Scott for however many minutes we have left.
All right, that was such great information, and we already have some questions coming in. Anyone that does have questions, I just want to take a moment to say that if you have specific questions about treatments for yourself, those are going to be questions we won't be able to answer today, because there's a lot of nuance and different situations that will be specific to you. And we certainly just don't know enough about you to answer those questions. But if you have any other types of questions, we're happy to answer them. Let's see, we have one here from Sanda. She says, I've got two questions for Dr. Haas. If a person suffered from pneumonitis with immunotherapy, can that person get another immunotherapy treatment?
It depends on how severe the pneumonitis is. We have plenty of people who have had a little bit of pneumonitis, and it gets better with steroid treatment. And usually, if it's better with steroid treatment and then you're off the steroid treatment and your lung condition, gets better, and you're not having any more side effects from it. If it wasn't too serious to begin with, sometimes it's worth trying it again, but often with the realization that you might need some steroid support. But it really depends. I mean, I've had other people that have had such severe pneumonitis that they're almost on a ventilator, and that's somebody that that I wouldn't go that route.
And then her follow-up question was, in Penn, sorry, I'm terrible with these scientific names, atezolizumab and bevacizumab and atinostat trial in the past. How does that trial go, and are there any hope for a trial that's FDA approved?
So atinostat is a drug that has epigenetic activity. It's a pill form, and unfortunately, it looks as if the company has made a decision not to go forward with that trial. They've closed a breast cancer study that they've also in the process of closing the kidney cancer study. I think that hopefully those kinds of drugs and that drug doesn't go away. I think probably the reason that it isn't doing well is that they're not studying sort of a specific enough group of patients to really know what the benefit is. So that particular trial looks as if it's in trouble.
Thank you. Then David Sexton asks, is there a difference in efficacy for pill form versus IV?
So the answer to that is probably not. I mean, it kind of depends on whether your kidney cancer responds better to one thing or another. I mean, some people's kidney cancer responds much better to immune therapy, and some it responds much better to the targeting the blood vessel. It has to do, it's not so much the pill versus an IV, it has to do with the mechanism of action of particular things that are available right now. I know that there's going to be a very important paper published soon that's going to talk a little bit about molecular profiling and whether some particular molecular tests that may be really informative as far as whether your cancer does better, is likely to respond better to an immune therapy or a therapy that targets the blood vessel. I don't know when it's going to be published, but I know that some of the researchers at Beth Israel and Georgetown are working on that publication.
And Sandra had a follow-up question in regards to, do you think that a pneumonitic suffered person can continue with immunotherapy with steroids?
Again, it depends on how bad it is. Sometimes, I have plenty of people that have a little bit of a cough and a little bit of fuzziness on their CAT scans, and we keep them on, on less than a 20 milligram dose of prednisone, and if they're feeling okay with that and it isn't getting worse, some of those people have continued on an immune therapy. I don't usually keep them on two immune therapies at the same time, maybe one, but it really depends on the situation, and it's it can be scary, so it's something that we usually watch pretty closely with follow-up CAT scans.
Well, we've The rest of the comments in the chat are thank yous for an excellent presentation. And I'd personally like to thank both of you for coming on and sharing your wisdom when it comes to kidney cancer and the different types of treatment options that are there. So thank you both for joining us today. If there aren't any other questions, then we're gonna call it here.
I was just gonna, I don't want to answer directly. There was one other comment there, but I think the question, it was somebody who's on one immune checkpoint drug and they're asking if you add a little bit of extra immune checkpoint, whether that works. And I think there have been some studies done recently that seem to show that if you get 2 immune drugs at the same time, you're more likely to have a complete response. If you go on one, you can add the second one, and there are some people that will respond a little bit better than that, although the number isn't quite as high as if you started with both drugs up front. The other question that people sometimes ask is, okay, if I'm on Ipi-Nivo, and then I'm on Nivo, and then my cancer starts progressing after a while, should I get Ipilimumab again? And that's really a question that there's kind of info all over the place with that. What I've heard from the company, from Bristol Myers Squibb at least, is the Ipilimumab kind of commits the T cells, the immune cells, to memory. And so you don't really need it a second time, but I don't think it's been kind of formally studied to that extent. So I know we didn't answer your question directly to that person, but because it's just too hard to do that, but hopefully that answers some of your question.
All right, the video for today's talk will be up tomorrow. And we also have the registration up for our next talk. If anyone would like to sign up for the Pediatric Oncology and Kidney Cancer discussion with James Geller, Dr. James Geller, on September 23rd at 1:30, that's 3 weeks from now. You can register now on our website, and we'll also be promoting that on social media. So again, thank you everyone. Have a great day, and I'll see you all next time.
Thank you.
Thank you. Thank you. Great job.